Good afternoon, everybody, and thanks for stopping for this final session. I'm going to give you just a brief overview about SHAPE. SHAPE, the acronym, stands for Strategic Health Asset Planning and Evaluation. It's a web-enabled, evidence-based information toolkit. It has a genesis in the NHS, but it informs and supports strategic planning of services. I think one point that's not entirely clear to me within the reformed NHS that's emerging is where exactly strategy is undertaken. In my view, it's an essential part, an integral part of service planning. So it has to be part of both a commissioner's perspective, it has to be part of a provider perspective. But sadly, on occasions, I think it's missing from the equation. SHAPE was developed by the Department of Health. It remains funded and sponsored by the Department of Health. Back in 2005-06, the pilot work was undertaken in Yorkshire. A couple of years ago, the Department of Health were keen to see SHAPE managed within the NHS, and the Strategic Health Authority in the North East of England volunteered to take on that responsibility. But the day-to-day running of SHAPE, its maintenance and development, is carried out by the North East Public Health Observatory. And only a year ago, we persuaded the Department of Health to extend access beyond NHS professionals to include local authority staff with a public health and or social care background, and in that way recognise the migration of public health to a local authority role, and acknowledge the potential for collaboration, co-location, integration of services between health and social care organisations. In terms of information within SHAPE, there's a whole range of information around primary care, clinical activity based on hospital episode data, public health, health inequalities information. We've got information on sites and facilities that are used for service delivery within the NHS, but including care homes and prisons and independent sector facilities, because they are all part of the provider pattern of service now. We've got outputs relating to demography, performance indicators relating to sites and facilities. All of that is able to be mapped, and the spatial dimension of SHAPE is a key element of it. There are plenty of other tools out there that will profile any elements of the indicators within SHAPE. There aren't many that will bring it together with the spatial distribution of sites and facilities in a location. We provide the information on a number of different boundary levels, initially for strategic health authorities and PCTs, more recently for clinical commissioning groups, recognise those boundaries need firming up, local authorities, and we're also able to present information for clusters of those organisations. So it's very flexible as a tool. We're actually trying to align SHAPE with 4 key policy objectives: joint strategic needs assessment, the quality, innovation, productivity and prevention agenda, QIP, transforming community services, and also generally supporting clinically led commissioning. So all of the data content within SHAPE is geared towards supporting one or more of those objectives. There's lots of other information in there that we could look at. We do try and rely on national data sets. SHAPE then provides the opportunity to benchmark data and compare and contrast between one organisation and another. This particular slide will give you some examples of the way in which SHAPE can underpin strategy. I'll let you read it for 2 or 3 seconds rather than go through them one by one. From my perspective, SHAPE helps commissioners assess levels of access to service. It relates service need to the service delivery points. It actually can help facilitate co-location of service, rationalisation of service, integration of service, driven by efficiency in some cases, but bearing in mind the need for good levels of access for patients and service users. And the spatial dimension provides that information and opportunity. SHAPE actually is best used not by individual disciplines, but in a multidisciplinary format. It can support unidisciplinary work, but if it's used by different disciplines, it tends to help people be more creative about solutions and service planning issues. SHAPE has some integral training and familiarisation facilities on site. There's a description of how to use the facility. There are regular training events. We're providing facilities for new users to engage in webinar presentations where we can actually do live demonstrations of the tool online for users all over the country. And there's an online help facility if anybody experiences particular problems during use. In order to use SHAPE, it works best with modern web browsers like Firefox, Safari, and Mozilla, but it is supported by Internet Explorer as well. Most important point for all of you who are thinking about and investing in and buying information from Dr. Foster's or others, SHAPE is free to registered users. DH have been very clear about that from the outset. I've lost count of the number of people who've approached me at events like this and said, we'd like to subscribe, we'd like to buy it. Sorry, it's not for sale, it's a free good. Don't reject it on that basis, it has value. This slide gives you, I think, a sense of the user profile of SHAPE and its history as an NHS developed product. So at the moment, the biggest number of users are hosted in primary care trusts or in NHS provider organisations. We've got a very, very small proportion of users in clinical commissioning groups and in local authorities. Now, clearly, there's a regime change taking place, and we need to try and make sure that the current use of SHAPE within PCTs migrates to CCG roles, migrates with public health into local authority use, and we're actively engaging local authorities now in exploring the potential of SHAPE. One of the things we're trying to do is take account of the emerging national outcomes frameworks, whether it's for public health or the NHS or adult social care, and let that drive our future information content. We're talking to one or two local authorities about importing their site location data for their own service delivery facilities, and we hope that that will enable us then to showcase better what potential SHAPE has for service integration work or just for work on behalf of local authorities. In particular, I think the range of data that's in SHAPE is of value to health and wellbeing boards. It underpins joint strategic needs assessment work that needs to be carried out. This slide gives a profile of the type of users by profession or role, probably not easily visible at the back, but mainly business development, information, estates and facilities, and public health roles. This slide gives a bit of feedback from users as to how they've used SHAPE in the past in their own strategic planning work. We will make these slides available through the conference organisers afterwards for people that are interested in them. And again, I'll not dwell on that detail. These are ways in which we're keeping our registered users up to date with developments in SHAPE. There's been, as I said, regular webinars. We issue e-bulletins on new content because SHAPE is not a static product, it's changing constantly. We're improving functionality, we're improving data content, and we're interested in feedback from users. We don't have a massive operational budget. We certainly don't have a massive marketing budget, but we're trying as best we can to use events like this to raise awareness of SHAPE and encourage people to take up its use. In terms of the future, We're looking to extend the content in relation to mental health indicators, in relation to the outcome frameworks that I've already indicated, and to reflect the emerging clinical commissioning group boundaries when they get firmed up. We're developing what we're calling a mixing desk, but actually it's a flexible reporting tool which will enable users to create their own indicators from information that's within SHAPE. So we're trying to make it more flexible and user-friendly in that way. It meets your own specific requirements. There are a number of examples at the end of the presentation just to illustrate the sorts of presentation that SHAPE can provide. It's a very, very simple format. Left-hand panel, indicator information. Right-hand panel, sites and facilities. Map provision in the centre for the display and the relationship of the two aspects of information. Very, very flexible in terms of use, and much easier now to use than it was 12 months ago. As I said earlier, I actually think that the spatial dimension of service planning is missing from service development work that gets carried out. If anybody's heavily involved in care pathway design, don't forget, you need to answer the question of where and how that care pathway is actually ultimately going to be delivered. That introduces, if it's not entirely in the patient's own home, it introduces the question of where are the sites and facilities that exist for that service to be delivered. SHAPE can help address all of those questions, and I would commend it to you for consideration as a free but very valuable good. Thank you.
So where we are now is in the very final session, which is an opportunity for you if you want to ask any questions of Anne or of Bob. But I also thought I would introduce a bit of equality into it, being as I've been a smiling assassin on the contributors in their timing, which is to say, if you don't want to ask a question but you want to make a contribution, great, but I will time you, and I have a stopwatch here. So, and I'm also going to give priority, first of all, to those who haven't asked a question or made a comment, but if we run out of those, then if you've spoken before, that's absolutely fine. So I'll give you up to 50 seconds. You may use it as you wish. It would be helpful if you just said, it's a question, and then I'll press the button, or it's a comment. Okay. So can I have some takers? Can I ask, first of all, anybody who hasn't yet in this forum contributed? Well, that means anybody then. Okay, so if the hands can go up. I've got 3. Anybody else? 4. I've got 4. You haven't contributed in this environment. We'll start with you and we'll come round. So if you can tell me if it's a question or a comment. Please.
Thank you. Nigel Jones, I'm a consultant geriatrician from Bristol. Am I allowed both?
Sorry?
Am I allowed both?
It's both. Okay. We'll give you, what should we give him, 60 seconds? We'll give him a minute. Go on.
So,
Bingsley's not spoken before. Go.
The comment, and certainly thank you from Anne Lloyd, who, yes, was an ex-chief executive. I don't think I was the consultant that she was referring to in the sense of some of the issues raised in Confidence of the Streets.
Certainly
but anyway. The patient's perspective, I think, is vital, and it is back to the patient-centred care. As a geriatrician, one of the issues that we have is about offering patient-centred, rehabilitative, proactive, life goal care from the point of entry to a secondary care trust. Also pre-entry to a secondary care trust. In other words, this is crossing the primary-secondary care divide, this chasm that still exists between our sort of services and or silos, as the word is often used. The question is what are the best ways of engaging people's hearts and minds in this? Because what seems to be happening, we're in a situation within our city that we've got 2 hospitals that were separate trusts. They divided in they became one in 97.
5 seconds.
They became one in 97, and we're now moving to one build. Everyone is saying they want to change, but no one's really prepared to go the mile to make that change.
Thank you. Very well disciplined. So if we can come here, please. And if you could give us your name and organisation and what it is.
Carl Freeman, Policy Manager. Question for Anne. Have you put a value on patient involvement and participation in the new Health Watch structures locally? And if not, do you think you ought to? Because that kind of consultancy would be well worth investment in.
17 seconds, point 1. Gentleman at the back, thank you.
It's a question. Thank you very much for giving me the opportunity to participate. I learned a lot from your distinguished speakers and networking during the breaks. Is it possible to use this movement of integrating social and health care to challenge the concept of always putting patients in the center, patient-centered, and replace them with a healthy individual or at least empowered client? Thank you.
Thank you. There's a wonderful discipline going on in asking questions. And gentleman at the front, from Cornwall.
Just for information to Anne, as a Pedance Town Councillor, for my sins, I'm also an older people's advisor. And the number of people who come to me with problems they have with health, and I advise them to go to PALS. I even help PALS at times. So that is the best way forward as far as that's concerned. Excellent conference. Best I've ever been to.
I might even give you more time for that. Hang on. No, thank you very much. That's very kind of you. Any more questioners or commentators? Yes, please.
Zohar Nouri from Croydon.
Question or a...
Question. CQC do unexpected visit and they sound the services and so on. And the patient care, like Anne was saying, you receive emails and people's stories and so on, but they must be a special group of people. How do you get into people who doesn't have these facilities? And is there a duplication of effort between CQE and that concern with you?
Thank you very much. Anybody else? Going. Gone. Okay. Perhaps I could invite, shall I ask Anne first of all, and then Bob to comment on where there were questions put to you. Thank you.
Thank you. Shall I start with you? And yes, I do agree. If you want people to contribute, if you want people and communities to contribute effectively, you should recognise their contribution, and you should be in a position to enable them to contribute. Certainly when you look at people, I've just been doing some research into mental health visions, values, mission statements, all the rest of it. And one organisation that I was researching had excellent rules on patient engagement, people's engagement, community engagement. And one of them with which I thoroughly agreed was actually you've got to recognise that they are taking their time to help you create a better care regime for them. And that, you know, they should be enabled properly. It might be that you have to provide transport or you have to provide some sort of acknowledgement in terms of resource. But, you know, this is nothing is a free good for most people. Except yours.
Apart from Shay.
Yeah. So I think that it's a very serious issue that has to be addressed. And that's why I said in terms of Health Watch and all the rest, these things have got to be funded to work properly. We've all worked on a wing and a prayer. PALS is having to work on a wing and a prayer half the time. So they do need to be funded properly and acknowledged because it's valuable information. Oh God, now the CQC and its unexpected visits, and I think you asked, how do you get people's views who haven't got emails and things like that? Well, that's what we're working with CQC on, and NHS Choices to some extent has patients, carers, community's comments about the range of care and the quality of care that they experience themselves. But we have got a different sort of database, and NHS Choices did want to work with us to access our database, but instead we're working with CQC to ensure that the information that we have given to us, which is extensive and over a fairly long period of time, can be used effectively to look at how these organisations do score in terms of the satisfaction of the community. And I think also I would encourage those organisers, CQC and others, and certainly ourselves, to work with local government and the voluntary organisations also to get a triangulation of the information that comes through from helplines, etc. What? Oh, PALS, absolutely. PALS are wonderful. I've been a big advocate of ensuring that individuals received help, and Bristol was one of the first with Brighton who implemented patient advocates within our hospitals and within our community service. So I think that it is really important that the information that the PALS have is also fed through and used effectively to give a more holistic view of the care that is available within a community. And you've got ears all over the place, so yes, I think you're doing an excellent job. Thank you. Now, Nigel, if I understood your question correctly, were you saying how do we turn the care system on its head?
We've got a situation where we're recognising that all the key players, actually the stakeholders coming from the consortium now as they develop their roles, are keen to have change.
Yeah.
And a lot of them are saying individually, we want to have complete change. It's the Einstein theory of insanity. We're recognising the need to differently. But when you try and make that into practice, there's great resistance.
Right. So it's how do you make change and really turn the planning system that we operate and the consequences for the care package that is available within an environment. How do you turn it on its head? Well, my goodness, we've tried to do this for years, but I do think that as a part of a planning system, and I will return to my own experience in Wales when we developed our long-term strategy for long-term conditions, which was years before England did, that in sitting and listening to the community groups, to the expert patients, with the clinicians in the room, general practitioners, social workers, you name it, they were all there to plan a care pathway together. What the expert patients had to say, what the communities had to say, because access is difficult, isn't it? There's no such thing as choice in Wales because you can't travel that far. It totally changed the way in which those care packages were designed and delivered. It turned them on their heads. We had the underpinning research and evaluation. We had the IM&T model, which showed which interventions for what type of dependent patient was going to have the greatest effect. And it was only by getting everybody in the room and having patience, because these things take time anyway, so you might as well use the time constructively, we actually completely changed the way in which we were thinking that we would be delivering this programme for the future.
Thank you. So, Bob.
Can I just perhaps comment on the question that was raised about whether it's possible to shift the focus from patient to health? I think Anne, in your own presentation, saw patient as a negative term in that sense. So let's just think about it for a minute. I think the word patient means different things in different contexts. So in a general practitioner primary care situation, it does have a more holistic sense than perhaps in a hospital setting where there's a specialty or there's a disease group classification as well that's normally added to the label. But even at general practice level, we've got more of an illness focus rather than a health focus. And certainly I'd like to see work in primary care shift away from that patient perspective towards a health perspective. No question about it. In a hospital situation where the division of responsibility and specialisation is so entrenched, I actually think that's much more difficult. Nevertheless, I think that people that get treated for a primary condition but have turned up with multiple underlying conditions do need treating and caring for with a much broader perspective than they sometimes get. So I actually think it is a desirable objective to move away from that patient perspective.
Thank you very much. Perhaps I could thank both Anne and Bob for not only speaking but also for being on the panel this afternoon. And I'm just going to conclude the afternoon by thanking not just Anne and Bob but all of the speakers for their contributions. Certainly from my point of view, I think it's been a very rich day and done by different types of people with different styles, with different contributions and thoughts, etc. And I hope you'll leave today knowing more and perhaps being more engaged and questioning than when you came in. Certainly I am. So I'd like to thank the speakers. I'd like to thank the workshop sponsors, who are WRVS, the NHS Institute for Innovation and Improvement, RNIB and Agencia, for their generosity in being sponsors, and my thanks also to all of the exhibitors, and of course my thanks to all of you, because if you hadn't have been here we wouldn't have had today. So thank you very much, and I wish you all a safe journey home and hope to see you again. Thank you.